Hello, Don here. Welcome to Podiatry Practice Mastery. We're going to go over Chapter 4 of the $1 Million Practice Blueprint. Specifically, I'm going to talk to you about the $1 Million Patient Visit Framework. So the design of the patient visit determines the practice's success. I didn't realize this early in my career. My visits were informal. A patient came in, we talked, I examined the foot, then I explained the diagnosis and quickly made a recommendation. Sometimes the patients followed through, and sometimes they didn't. Eventually, I realized the visit needed a structure. So, what is the $1 Million Patient Visit Framework? Every visit now follows 5 steps. Okay, so evaluation and diagnosis, patient education, a treatment plan, immediate treatment, and then a recovery schedule. So let's look at each step. So number 1 is evaluation and diagnosis. This is something that, as podiatrists, we all know how to do this. Your patient needs confidence that you understand the problem. I start with the physical exam. I do a gait exam. I review the imaging. I often say something like this: the reason that you're having the pain in the plantar fascia is because it's inflamed. This brings clarity and this builds trust. One thing I've learned even recently is I tend to be very, thoughtful, and I like to do different types of exams, look at their foot, look at their x-ray, and I don't usually verbalize what I'm doing or what I'm seeing or what I'm analyzing. But I learned this from someone else. It's called a running commentary, and I find that patients like it much more when we say and we verbalize what we're seeing. So I verbalize, okay, I'm touching you on your pulses. Your pulses seem good, and that means you have good circulation. So saying what you see and what that means. I'm feeling here around the bottom of your foot. You have pain to the bottom of the heel. That's where the plantar fascia inserts, and so that means that you have plantar fasciitis. I can see here you don't have much range of motion in your ankle, so you have tightness, you have equinus, which means you have a tight calf muscle, okay, and that is contributing to the heel pain or the plantar fasciitis that you're having. As I'm looking at your x-ray, I can see that you have good joint spaces, you have some spurring in the middle of the foot. That indicates you have arthritis. You have some collapsing here in the middle of the foot. That shows that you have pronation. You have this bone that's uncovered, which is talar head uncovering, which just means that you have a flattening of the foot. So these types of explanations I'm actually doing verbally now with my patients for a couple of reasons. One, because it helps my scribe, because he's the one that's doing all the notes for me. But second, it's showing them that this evaluation and diagnosis shows the value in what you know. And a lot of times we're doing this, but we're just documenting it and we're not verbally telling it to patients. So I think one of the benefits of having a scribe is actually you are documenting this whole process. The second aspect would be patient education. This is where many patients rush, and as patients, they need to help understand what's the condition, why it developed, and how it can be fixed. So the condition, I usually just use their foot to show. I might use a foot model, and many times I use something called a patient presentation. So if you want to learn about the patient presentation, you go to patientpresentations.com. Basically, they are Google Slides I have for each condition, and it has an anatomy slide, an ultrasound slide, and there's a few that I use, and it goes through kind of the treatment process for patients. I talk about the condition, I talk about kind of what caused it to develop, where they got it from, and then how it's fixed. That's the most important thing for them. And I usually show diagrams or different types of things in my patient presentations or that are on my treatment sheet. Next is step 3, which is the treatment plan. So instead of a vague recommendation, I like to give my patients a clear plan, and this is usually on my treatment sheet. Okay, I always offer, once again, the best treatment to patients, and I let them say that they would like to do anything less. So for example, my treatment for many of the musculoskeletal things on an ultrasound where there's thickening of the tissue of a posterior tibial tendon or of a peroneal tendon or of a plantar fascia or of the Achilles tendon, I always talk about doing shockwave therapy with an amniotic injection to reduce inflammation and to help with healing, but also to stabilize the foot with an orthotic. I recommended custom orthotics always to help prevent the condition from returning, and I recommend a stretching program with a night splint, foam rolling, to help reduce the tightness. So this is what I do for plantar fasciitis. And then I think a big key is I try to give them immediate treatment whenever I can. So many times when a patient's in there and I go over this and say, and I can check and see if we have time to do shockwave. Now, most days I do have time. Sometimes I truthfully don't. I'm too busy. The shockwave is already busy. They're not, the patients don't want to wait. But whenever possible, I like to do treatment. And I don't have patients come back for nail procedures, I do them the same day. I don't have patients come back. Usually like an exostectomy or a flexor tenotomy, I'm going to have them come back. But for most things like shockwave, scanning for orthotics, it's a real quick process. So anything that you can make it streamlined, I found that switching from plaster casting to scanning makes it a lot easier to do the orthotics the same day. And this also helps builds patients a feeling of trust in you. So doing injections same day, shockwave, orthotic scan, procedures, starting treatment immediately builds this momentum. And then another thing, I think it's important to give patients a recovery schedule. I like to map out the timeline. So when I'm doing shockwave, I'll say we're going to do 6 sessions of shockwave. Ideally, we're going to do them once a week. I like to do the 6 sessions within an 8-week period. So if I'm on vacation or something else like that, that's okay. I also offer them, some patients, they want to do this quicker. So if you're in a rush, theoretically, you can do it every 72 hours. So every 3 days, you can do shockwave and it'll work. So that's something that we do. And I say, and you should usually feel better by about week 5 or week 6. And I say this specifically based on my experience. So some are 5 or 6. I think for insertional Achilles tendinitis, it might be a little bit longer. I think for fractures, it might be a little bit faster, depending on how healed the fracture is, and if it's like a non-unit I'm trying to deal with. I'm going to say we're going to do an amniotic stem cell injection at week 2. We're going to do orthotics at week 3, and then we're going to do a 6-week follow-up with you. So how I exactly word this to patients is we're going to do 6 sessions of shockwave, and usually at the 2nd session, we're going to perform an amnio injection, and at the 3rd session, we're going to scan you for orthotics. That'll be dispensed at your 6th session of shockwave. I notice that patients start to feel better around week 5 or 6 as the tissue process is healing. Sometimes it can take longer. And patients feel confident because they understand the plan. I think this is important. Same thing with Swift. We're going to do 4 sessions of Swift. They're once a month. Or we're going to do 6 sessions of laser for your nails. We're going to do them once a week. And then 2 months later, the 5th, and then 2 months later, the 6th. So having these so they know kind of the expectation, you're going to start seeing some improvement with nail fungus at month 3. It's about 1 millimeter a month. So things like that. I think these are real important to explain expectations. As you start to explain it this way, they follow the structure. Patients understand their condition, the treatment acceptance increases, and your overall outcomes improve, and the practice grows naturally. So I'd like to write down, if you could, write down the current structure of your patient visits. How is it that you treat them? You all know how you treat them. I know many times doctors have a hard time articulating this. Well, I treat everyone a little bit different. Well, you do a little bit, but for the most part, we treat them the same way. And then compare it to the $1 Million Visit framework. Like, what are those 4 or 5 conditions that you have these high revenue treatments? Now, if you don't have these high revenue treatments, it's something that you should consider, because it's really hard to get to $1 million practice if you don't have some of these high revenue treatments. And I'm not saying, like, the number one thing for me, actually, for my practice would be Swift, but maybe for you it would be AFOs. Like, if you're doing tons, I know some doctors that do just tons of these balance braces or AFOs. I know other doctors that do tons of wound care and they do collagen. And so whatever your area of specialty is, you can do it with that specialty. You just have to figure out what your MVP patients are and cater to them, and then start standardizing this process. So small improvements in visit design create an enormous long-term impact. So next we're going to discuss a simple tool that dramatically increases productivity, and this is using staff appropriately. So I hope you guys found this last chapter beneficial. This is one of my favorites, and this is something that I talk a lot about, is this framework, this way of treating patients, a way that is ethical, but a way that is comprehensive. Because in the past, I was never taught to treat this comprehensive approach. And so even if you're going to increase or start doing a new technology, you really have to think well of how you're going to implement this. So even something simple is, if you're going to do a prefab insert, like, make sure they can't get it somewhere else. Make sure it's a good quality. I have a nice one that I like from Northwest. And then when patients don't accept a custom, you can kind of offer that prefab, or you might even want to offer a prefab first. Or if you're going to be doing Swift, you really have to have a process of how to explain it. I think one of the biggest challenges for many doctors I see is they buy these expensive technologies like Swift or like Shockwave or like ABIs or ultrasound, or buying these amnio injections or Lipizana, and they can't really explain it. They don't really have a great explanation of who it's appropriate for, and they're not offering it for the first line treatment for patients. And I think this is one of the big challenges where people get frustrated where they buy these technologies and then they can't use them because it's not easy. It's not easy to do this on your own. Okay, it takes kind of practice. That's why I've kind of put in all the reps to kind of explain what's working for me. Now, if something works better for you, I'd love to know. Tell me what's working for you. I can share it with everyone else on this podcast. Okay, so once again, if you want the whole PDF download of this book, go to podiatrypracticemastery.com/book. You can download the whole thing. And we'll talk to you more, go over this next chapter at the next podcast here.